Good evening, dear all. Good evening, sir. Yes. Good evening. So, for today's webinar, it's ischemic perfusion injury, an interesting case will be discussed by Dr. Vrushali Deshpande. She is renal and transplant pathologist at Max Super Specialty Hospital, Nagpur. She has done the PDCC Renal and Transplant Pathology Fellowship at Apollo, also done Clinic Nephropathology Certificate course ISNANIO, an advanced course in that also, and 17 publications in various index journals. So we are very eager to hear you, Dr. Vrishali. Over to you.
Evening to all. Thank you, Dr. Radhika Madam, for kind introduction. And I'm thankful to Indian Society of Organ Transplantation for giving me this opportunity to deliver a talk today. Today's topic is about ischemia reperfusion injury in kidney allograft. Now, ischemia reperfusion injury is a pathological condition due to initial restriction of blood flow, that is ischemia to an organ, followed by subsequent injury due to restoration of the perfusion and concomitant reoxygenation. Now, why it is important to understand this concept? Because it is inevitable after kidney transplantation, first thing, and it is one of the most important cause for non-function or delayed graft function. Apart from these short-term outcomes, when we think of long-term graft impact, the ischemia reperfusion injury is associated with increased risk for acute and chronic rejection episodes and chronic graft dysfunction due to IFTA. So, outline of the talk will be, we will understand the pathophysiology of ischemia reperfusion injury at the cellular level, its consequences, then what are the reflections on morphology, how understanding this concept can help us in a practical manner for interpretation of our biopsies with a small case discussion, and a brief about the prevention strategies to avoid the ischemia reperfusion injury. So let us dive into the pathophysiology of ischemia reperfusion injury. We know the allograft is subjected to ischemic injury because of prolonged warm and cold ischemia time. And we can expect these ischemia times to be more in disease organ donation after brain or cardiac death because of increased hemodynamic disturbances, Second thing, the second ischemic insult occurs at the clamping of renal artery during harvesting surgery. And third thing, the cold ischemia, the allograft is subjected to during storage, and this ischemia time depends on the preservation modality which is being used. Now let us see what happens at the cellular level. We all know ischemia is the injury because of decrease in the oxygen and nutrient supply to any organ. Now, what happens when there is decrease in the oxygen supply? We know cell, they thrive on ATP. As the oxygen goes down, the aerobic glycolysis goes down. There is depletion of the ATP. ATPs are required for maintaining cellular hemostasis. It is required for operation of different ionic pumps. And as the ATP deplete, there is inhibition of sodium-potassium pump. There is retention of sodium in the intracellular compartment with subsequent cellular edema. And this increases the chances of enzymatic activation and cellular lysis. Second thing, at this point of time, there is increased generation of reactive oxygen species. Third thing, as the ATPs go down, the aerobic glycolysis go down, the cell shifts its metabolism to anaerobic glycolysis. There is generation of lactic acid, the pH of the cell drops, and pH is very much critical for maintenance of the cellular stability. When the pH decreases, there is acidotic environment at the cellular level. The lysosomal membranes, they become unstable. There is release of various lysosomal enzymes, and these enzymes, they are harmful for cell itself. It causes injury to the cytoskeleton, cellular membrane, the mitochondria, and the cell is subjected to necrosis and apoptosis. So all these things are happening because of ischemic insult and decrease in oxygen supply to the organ. Now let us have a look at what happens when there is reperfusion. When the blood store is restored, the oxygen supply is restored to the organ. And because of that, there is in the compromised milieu of ischemia, after the organ is getting oxygen, there is burst of reactive oxygen species, which are harmful to the cell, to the mitochondria and the cellular membrane. Apart from that, there is increase in the intracellular calcium load, which activates various caspases and capsins, which are enzymes initiator for apoptosis. So cell here is landing up in injurious process of necrosis, apoptosis, and autophagy. Now let us have a look at what are the consequences of this injury at the cellular level. We have seen the cell is getting programmed to necrosis, apoptosis, regulated necrosis, and autophagy. Apart from that, the very important component of ischemia reperfusion injury is endothelial dysfunction. The endothelium is also prone for ischemia. Because of the ischemic insult, there is increase in the vascular permeability, leakage of fluid in the surrounding interstitium, interstitial edema, and there is a failure of the vascular pericytes to relax. They are more prone for vasoconstriction and more prone to not get relaxed. And this phenomena increases the impedance of the restored blood flow at the microcircular level, which causes the phenomena known as no reflow phenomena. After some time, it heals on its own and the circulation is again restored. Apart from that, what we get the damaged endothelial cells, which are expressing various damage associated molecules, and they are recruiting the inflammatory cells, most commonly the neutrophils. There is increase in the attachment of neutrophils to the endothelium, rolling, transmargination, and the same thing is reflected on morphology in the form of neutrophilic infiltration in the microcirculation of the graft. The endothelial insult again is a trigger for complement and coagulation activation. which we get in severe type of ischemic reperfusion injury in the form of fibrin thrombi in the glomeruli. So these two things are happening at the tubular and endothelial level. As we know, the tubular cells and the endothelial cells in a kidney are very much prone for ischemic insult. Now, we know our body has a mechanism for handling any injurious insult. And in response to injury, it reacts in the form of inflammation. And there is activation of both innate and adaptive immune responses in response to ischemia reperfusion injury also. The cells which are landing up in necrosis and apoptosis, they express various damp and disease associated molecules on the cell surface. And these DAMs, they attract various toll-like receptors on the inflammatory cells. Again, the expression and interaction of DAMP and these receptors, they increase the translation of various chemokines in the cells. The micromilieu turns into pro-inflammatory micromilieu. There is complement activation also. Now, one more important cell in this immune responses is a dendritic cell. Now, dendritic cell is an antigen-presenting cell, and what it does, it expresses the damaged antigen and to the T cells or the cellular immune cells. And the cellular T cells, they become prone and they recognize the alloantigens from the graft. We know the T cells and B cells, they are interlinked, and in such a injured micromilieu, with the help of prime dendritic cells, prime T cells, the allograft HLA antigens, they are expressed to the recipient's T and B cells, and this creates a ground for future episodes of rejection, both acute as well as chronic rejection. So, so far we have seen how ischemia and reperfusion, it is damaging the kidney allograft cell and how the body is reacting to it and why the injured organ is prone for episodes of rejection. Now let us see what can we expect on morphology in such type of situations in an allograft. We just have seen that tubular epithelial cells, they are very much prone for ischemic damage. At the level of ischemia, we can expect some amount of tubular injury and tubular necrosis. And when the blood store is restored in the phase of reperfusion, we are getting again tubular injury. But at this time, we can expect some interstitial edema, recruitment of inflammatory cells in the interstitium, then the endothelial damage. The endothelial damage, it attracts the neutrophils and macrophages. There is exposure of the subendothelial procoagulant tissue. We can expect some activation of complement and coagulation in severe damage to the endothelium. And one more important thing, when the injury is severe, there is one phenomenon known as endothelial mesenchymal transition occurring in the endothelium. The endothelial cells, they lose their endothelial phenotype gradually and they acquire a mesenchymal phenotype. Now, mesenchymal cells, they are precursor for fibrotic tissue. And because of this endothelial mesenchymal transition, these cells, they lay down a fibrous matrix and it creates a ground for interstitial fibrosis and tubular atrophy, which on a long-term basis are hazardous for graft, and it creates a background for chronic graft dysfunction. So, looking at this background, now let us see how understanding the concept of ischemia reperfusion injury can help us in interpretation of transplant biopsies. When we think about ischemia reperfusion injury, we just tend to think that it will limit itself to just the tubular compartment and we expect just tubular injury. But apart from that, as we have seen, it has a very important damaging implication on the endothelium and microvasculature, and it can create microvascular inflammation in the graft and thrombotic picture like thrombotic microangiopathy also. So let us have a look at a small case discussion which we recently came across a few months back. This is a transplant biopsy of a 50-year-old male. Patient was hypertensive. He received a graft from 48-year male with history of hypertension and IC bleed. At the time of transplantation, the serum creatinine was 3.4 milligram per deciliter. At this point of time, we are expecting tubular injury in the allograft. Uh, his pre-transplant workup showed serum DSA positivity for class 1 antigen with an MFI of 1597. Class 2 antibodies were negative. His CDC and flow cross-match were also negative. And still, the transplant team decided to go ahead with one session of plasmapheresis. His cold ischemia time was 4.5 hours. Uh, but unfortunately, after the anastomosis, the implanted kidney was not looking very healthy. It had a dusky and flabby appearance. And the transplant team was concerned whether they are dealing with some kind of rejection episode considering his immunological background and whether such kidney should be kept or removed. So what to do at this point of time? They thought of going ahead with frozen section evaluation, and the frozen section were looking like this. Now, the good thing is that the telltale signs of hyperacute rejection, which are severe hyperemia, congestion, hemorrhage, necrosis, prominent microvascular inflammation, none of these were present in the graph. We could appreciate there was some amount of tubular injury and relatively normal appearing glomeruli. There was no evidence of coagulative necrosis. So the same things were conveyed to the transplant team and they were relieved that they are not dealing with any type of necrosis or severe hyperacute rejection. So at this point of time, we might think of what could have happened in the allograft that it was looking dusky and flabby. So we might think that the phenomena which we just discussed, that is no reflow phenomena after restoration of blood, that the microcirculation becomes so resistant and applies impedance to the restoration blood flow that the blood flow cannot pass. Because of ischemia reperfusion injury, the vascular pericite, they fail to relax. There is persistent state of vasoconstriction. And this phenomena of no reflow might have caused that appearance, dusky appearance of the kidney. Fortunately, the graft was retained, the surgery was completed, and during surgery only, after some manure and after some time, the kidney gained the good color and it started looking healthy. But considering this background, the immunological background, still, and the oliguric status of the patient, post-transplant biopsy was performed on day 2. And the biopsy showed, as we expected, showed moderate amount of tubular injury. At this magnification, we can see there is tubular injury with relative dilatation of the lumina. The glomeruli are looking okay. There is no evidence of necrosis. The interstitium is not showing much inflammation, and the cellular rejection process is nearly ruled out. The artery is showing intimal fibrosis. Coming to the high power, we can again appreciate the tubular injury. There is some amount of cellular blabbing, simplification of the lining, dilated lumina, relatively okay glomeruli. And on still high power, we can see there is prominent microvascular inflammation though. The capillary loops, they are filled with neutrophils. The PTCs are congested. Here also they are showing some neutrophils in the lumina. This is one more PTC, which is showing neutrophilic infiltration. So to summarize the biopsy the C4D immunohistochemistry was negative, which ruled out the possibility of humoral rejection. So to summarize the biopsy finding, we had moderate amount of microvascular inflammation. C4D was negative, which ruled out the possibility of ABMR. There was prominent acute tubular injury. some amount of chronicity which was donor related, and the possibility of ischemia reperfusion injury was thought of. Now, at this point of time, when we are getting microvascular inflammation in an allograft, the most important differential diagnosis becomes acute antibody mediated rejection. But for our help, we have C4D. This is a nice paper by Mark Haas and colleagues published in Transplantation, who studied C4D staining of perioperative renal transplant biopsies. And what they found was C4D staining and positivity is associated with humoral rejection as well as just the presence of donor-specific antibody at times. But the important thing or derivative was the C4D positivity is not observed as a feature of ischemia or ischemia reperfusion injury in this study in a perioperative renal transplant biopsy, including those cadaveric grafts with cold ischemia time as long as 41 hours. So, in early post-transplant period, if the biopsy is showing microvascular inflammation and our differentials include ABMR, C4D, and serum estimation of DSA will help us to point the etiology towards humoral rejection rather than involvement with severe ischemia reperfusion injury. Now, again, coming to the same situation of early post-transplant biopsy, as I told, if we are getting microvascular inflammation with or without fibrin thrombi, the differential diagnosis is very large, including ischemia reperfusion, including humoral rejection, and including various causes of TMA, such that drug-induced TMA, recurrent HUS, or it might be because of TMA due to ABMR. The interpretation of such type of morphological picture, we have to take into consideration the clinical background, whether the situation was like more warm and cold ischemia time, situation like disease donation, then we can think of prominent ischemia reperfusion injury. Situation with pre-transplant immunological workup positive for some DSA and C4D positivity, we can attribute that microvascular inflammation to humoral injury to the graft. And situations like increased tacrolimus level, relatively non-inflammatory thrombi in the glomeruli, we can think of drug-induced TMA. So interpretation of these morphological findings, we always have to take into consideration the relevant clinical data. Now, to summarize the ischemia reperfusion injury in a kidney transplant in a nutshell, we have seen at the cellular level how ischemia is causing damage to the tubular and endothelial cells, how it is playing into action and causing formation of reactive oxygen species, and it is damaging the cell, causing necrosis and apoptosis, and how after this initial insult, it is priming our innate and adaptive immune responses and making a background for future episodes of cellular and humoral rejections. Apart from that, the endothelial mesenchymal transition and how it is predisposing the graft for chronic allograft injury and IFTA. Coming to a brief slide about how can we prevent the ischemia reperfusion injuries in an allograft. The most important aspect are optimum donor management, accurate surgical technique, and reduced cold ischemia time with adequate perfusion, either by using the machine perfusion technique or by manual technique. And apart from that, there are some newer modalities mentioned in the literature and many drug trials in pipeline, including the concepts of ischemic preconditioning of the graft, use of therapeutic gases like nitrous oxide, use of antioxidant therapies like SOD, then inhibition of innate immune responses, including complement inhibition, manipulation of dendritic cells, all these therapies, they are at experimental animal model levels, and still they are not reflected in clinical transplantation management. If we go on and want to dive in detail about the discussion we just had, these are few interesting references, and these are my references. If there are any questions, they are most welcome. And thank you for your patience hearing. Thank you.
Then is like patient response ISOT. There are many plates. Dr. APJ Abdul Kalam Health Excellence Award 2024 for excellence in kidney pathology, and there are various publications in national and Madam will be presenting, giving a course summary this course in nutshell. Congratulations, ma'am, for successfully conducting this course, and over to you.
Good evening, everyone. Today's talk, I will be focusing on core graft pathology, that is rejections, CNI toxicity, and infections in a case-based approach to make it more interesting. Case first, 54-year-old male, ESRD of unknown etiology, on maintenance hemodialysis for 3 years, underwent living donor renal transplant with brother as donor. Patient is on triple drug immunosuppression. His baseline creatinine is 1 milligram per deciliter. Now came with serum creatinine of 3.3 milligrams per deciliter. 3 months post-transplant, graft dysfunction is there. Urine protein is 2+. There is active urinary sediment. TAC level is 7 nanograms per ml. Clinical DD, allograft rejection versus native kidney disease recurrence versus TAC toxicity. So this is a cortex scanner view HND stain section showing these ball-like structures as glomeruli, tubules, and interstitium. Glomeruli looking normal. There is mild tubular injury with loss of the brush border and diffuse interstitial inflammation. So eye inflammation evaluates the score in the inflammation in the degree of inflammation in the non-scarred cortex. Here it is diffuse, so it becomes I3. There is tubulitis. The tubules should be longitudinally cut, and there should be at least 10 tubular epithelial cells should be there per tubular cross section. Tubulitis is infiltration of tubular basement membranes, these tubules, by mononuclear cells at the basolateral aspect of these tubular epithelial cells. These mononuclear cells have smaller, darker nuclei and a perinuclear halo. These nuclei are smaller and darker as compared to tubular epithelial cells. It is graded as mild, moderate, and severe. Mild is when there are 1 to 4 mononuclear cells are seen inside the tubular basement membranes. 5 to 10 is moderate, and more than 10 is marked or severe tubulitis. There is peritubular capillaritis. Peritubular capillaries are these capillary in between these tubules. So identify the capillary basement membrane, thus endothelial cell, Identify it is inside this capillary lumina, these inflammatory cells, and not in the interstitium. At least 10% of peritubular capillaries should be involved by this inflammation to call it peritubular capillaritis. Mild, moderate, severe grading is given like that of tubulitis. Here it is mild peritubular capillaritis. Is this endarteritis? First of all, to qualify an artery, at least 2 smooth muscle layer should be there in the tunica media. This is an artery. These endothelial cells, these are elongated, light colored, present, and these darker mononuclear cells or lymphocytes are just sticking to the endothelium, but they are not uplifting the endothelium like in this other case of true endarteritis. This is graded according to the luminal occlusion V1, V2 and mural involvement. If the tunica media, that is muscle layer, is involved by fibrinoid necrosis, then it becomes V3. So there should be upment of the endothelial cells and the lymphocytes should sit beneath the endothelium. C4D was done by IHC and it is negative in the peritubular capillaries. So it was a case of marked interstitial inflammation, I3, marked tubulitis T3, consistent with acute T-cell mediated rejection, Banff grade 1B. Remember, we can see both combined ABMR and TCMR cases also. According to Banff, TCMR starts from the category 3, suspicious for borderline TCMR, where the tubulitis is mild and interstitial inflammation is also mild. Interstitial inflammation should be at least 10% to score it I1. If it is less than 10%, it is I0. So when it is at least 10% and T1, 1 to 4 cells in the pertubular cross section, then we can consider it as borderline T-cell mediated rejection. Irrespective of the tubulitis, if the inflammation is mild, then also it is suspicious for TCMR. Irrespective of the inflammation, if the tubulitis is mild, then also it becomes borderline TCMR. So category 4 is T-cell mediated rejection, acute TCMR, when there is moderate to marked interstitial inflammation, but tubulitis is moderate, and 1B is when there is marked tubulitis. Grade 2A, where the vessel involvement is there, V1, that is less than 25% of luminal occlusion, V2, that is grade 2B, when 25% or more of the luminal occlusion is there, and grade 3 is V3. Case 2, 43-year-old male, hypertensive, and ESRD of unknown etiology, live related renal transplant recipient, mother as donor, now 4 years post-transplant, with no follow-up for last 1 year, non-compliant with medication, came with pedal edema of last 1 month duration, no fever or any other systemic symptoms of infection or nephritis. BP is 160 by 100 millimeters of mercury. On investigation, serum creatinine is raised to 6.7 milligrams per deciliter. PCR for CMV and BKV is negative. DSA is negative. Urine culture is sterile. TAC level is 2.2 nanograms per ml. So DD was allograft rejection. This is HND stain section of renal cortices of the same allograft biopsy. Here we see there is loss of tubules, or the tubules have been atrophic. They have reduced in size and they are atrophic. So moderate amount of chronicity changes are seen, tubular atrophy and interstitial fibrosis. And I-IFTA, that is inflammation in this IFTA area, that is the extent of inflammation in the IFTA area, it is diffuse. So it becomes I-IFTA 3. And TI is total inflammation, that is I-IFTA, that is inflammation in the scarred cortex, and I, that is inflammation in the non-scarred cortex. So here we can see there is tubular injury with the loss of brush border and moderate amount of interstitial inflammation. So TI also becomes 3. So there is marked interstitial inflammation. Here on PA stain, we appreciate better the tubular atrophy. There is wrinkling and thickening of this tubular basement membrane, reduction in their size of tubular lumina, and there is interstitial fibrosis and inflammation. And the glomeruli appearing normal. These are the normal tubules. One artery is here and it is appearing normal. So T-IFTA is scoring of tubulitis in areas of interstitial fibrosis. It is graded according to presence of mononuclear cell infiltrate in the non-atrophic, mildly atrophic, that is less than 25% of diameter of normal tubules, and moderately atrophic, that is less than 50% of diameter of normal tubules. It is scored. Like in tubulitis also, we can score in non-atrophic, mildly atrophic and moderately atrophic tubules, but in the non-scarred area, T-IFTA is in the scarred areas where the interstitial fibrosis is there. So it is T-IFTA. This is moderate T-IFTA in this section. These are the atrophic tubules. The tubules are not here back to back, and there is some interstitial fibrosis and mild interstitial inflammation. This is IFTA 1, and here we can see there is mild to moderate tubulitis. So it becomes T-IFTA 2. Severely atrophic tubules. These are the severely atrophic tubules where we cannot score tubulitis or T-IFTA. So T-IFTA, yes, because there is wrinkling and thickening of this basement membranes and reduction in the size of the tubules. Also in endocrine type of tubular atrophy, we cannot score tubulitis. So CV, other artery was showing this is mesenterichrome strain, and this is internal zigzag appearing internal elastic lamina. This is tunica media, and adventitia is mixed with the interstitium. So this intimal fibrosis is graded as CV, and it is graded according to the luminal occlusion. Here it is mild. And what is transplant arteriopathy or sclerosing transplant arteriopathy? This is seen in cases of chronic TCMR or chronic ABMR where there is no elastosis. This internal elastic lumina, it is not seen here. There is no elastosis, but still intimal fibrosis is seen, and there is infiltration of these mononuclear cells in the intimal fibrosis. So our case was showing moderate tubulointerstitial changes of chronicity, marked tubulitis, moderate inflammation, interstitial inflammation, consistent with the diagnosis of chronic active T cell mediated rejection, Banff grade 1B. So to grade Banff score, we should have the adequacy criteria, at least 10 glomeruli and 2 arteries should be there, or minimum criteria is 7 glomeruli and a single artery should be there. So in Banff lesions, chronic active TCMR grade 1A, when there is moderate interstitial inflammation in the atrophic, around the atrophic tubules or in the fibrosed like interstitial fibrosis area, should be moderate, and tubulitis should be moderate. Total inflammation also should be moderate at least. So it starts with grade 1A, and when there is marked tubulitis, 1B, and grade 2 where the vessel is involved is sclerosing transplant arteriopathy. So whenever we see IFTA on an allograft biopsy, so these are the possibilities we should think of: rejections, whether it is TCMR or ABMR, chronic or chronic active; CNI toxicity, polyomavirus nephropathy, recurrent or de novo glomerular diseases. Glomerulitis is seen in ABMR, tubulitis is seen in TCMR and also in polyomavirus nephropathy. Peritubular capillaritis is seen in chronic rejections. Endarteritis is seen in rejections. Peritubular capillaritis and endarteritis are seen in rejections. C4D positivity is seen in ABMR. IFTA is seen in all. Transplant glomerulopathy, that is duplication of the glomerular basement membrane, is seen in chronic active or chronic ABMR, or in CNI toxicity where TMA changes are seen. PTCML, that is peritubular capillary multilayering, it is seen in chronic active or chronic ABMR. Transplant arteriopathy in both rejections. Striped fibrosis is diagnostic for CNI toxicity. Also, nodular arteriolar hyalinosis is for CNI toxicity. IHC for SV40 positivity is seen in polyomavirus nephropathy, and immunofluorescence to rule out any recurrent or de novo glomerular diseases. Case 3, 48-year-old male, post-kidney transplant 2 years, donor being wife, native kidney disease, chronic interstitial nephritis, hypertension of new onset, serum creatinine raised to 2.65 mg per dl. So here we can see low power view of HND stain section showing glomerulus and tubules and interstitium. There is mild tubular injury with flattening and denudation of the lining epithelium along with loss of the brush border. And on further magnification, we see this is the glomerulus PA stain, and there is segmental glomerulitis. This can be segmental or global, and this G score is glomerulitis, inflammation within the glomerular capillary lumina. It is graded according to number of glomeruli involved. So there should be endocapillary cell enlargement, which is and occlusion of capillary lumina by at least one inflammatory cell. And endocapillary cell swelling, the term is now outdated. Endocapillary cell enlargement, that means it is showing lot of cytoplasm, and occlusion also should be there by another inflammatory cell. So this qualifies the criteria for glomerulitis. There is mild tubular injury with loss of the brush border, and there is peritubular capillaritis. Here it is moderate peritubular capillaritis. C4D was diffusely positive. It is linear, strong, linear continuous positivity along the peritubular capillaries, and along the GBM was also seen in our case. So this was glomerulitis, peritubular capillaritis, and C4D positivity, showing features of suspicious of active antibody mediated rejection. Serum DSA was positive, so gave as active antibody mediated rejection. So according to now recent ban 2022, category 2 is antibody mediated rejection, and also the term MVI, that is microvascular inflammation, is added. We'll see active ABMR, which was our case. So the three criteria must meet for the diagnosis. Criteria first is light microscopy findings of at least one of the following: microvascular inflammation, that is glomerulitis and peritubular capillaritis should be there. Transplant endarteritis or TMA. Criteria 2, evidence of one or more of the following, that is C4D positivity should be there either by IF or IHC, IF being very sensitive, and moderate microvascular inflammation should be there, and there is increased expression of NDATs. Criteria 3 is donor specific antibodies to HLA or non-HLA antigens in the serum. Coming to next case, this is 24-year-old male, living donor renal transplant with mother being the donor on triple immunosuppression, uneventful course for 3 years post-transplant, lost to follow-up for last 1 year, compliance to medication is questionable in the last 1 year, now has asymptomatic graft dysfunction. Serum creatinine is raised to 2.6 milligrams per deciliter, TAC level is reduced to 3.2 nanograms per ml, USG showing raised parenchymal echotection. Clinical DD is allograft rejection or native kidney disease recurrence. This is HND stain 20X showing a glomerulus, few tubules, and peritubular capillaries. So the tubules are showing the tubular injury. There is loss of brush border, and some mild peritubular capillaritis is also seen. Now coming to the glomerulus, it is showing some thickening of the glomerular basement membrane, but we should not comment on HND stain. We should comment the thickening only on PAS and silver stain. There is some glomerulitis also seen, segmental glomerulitis. I can identify the neutrophils showing the trilobed nuclei. So there is segmental glomerulitis, mild peritubular capillaritis, and tubular injury. On further evaluation on PA stain showing duplication of this glomerular basement membrane along with this mesangial cell interposition. So this is called as CG, that is transplant glomerulopathy. There is glomerulitis also seen. On silver stain also, there is at least 30% of this glomerular basement membranes are involved in duplication and showing the mesangial cell interposition. So this is graded according to severely involved glomerulus. CG1A is seen only on electron microscopy. On light microscopy, CG1B is seen. So, and C4D was diffusely positive. It was showing strong linear continuous positivity along the peritubular capillaries and along the glomerular basement membrane. So it was a case of transplant glomerulopathy, transplant glomerulitis, mild tubular injury, moderate peritubular capillaritis with diffuse C4D positivity, suggestive of an chronic active antibody mediated rejection. So chronic active antibody mediated rejection criteria, 3/3 criteria should be there. So what are these chronic lesions of AMR? Active lesions were glomerulitis, transplant, peritubular capillaritis, acute TMA changes, or transplant endarteritis were there. Now chronic lesions are two, that is CG and PTCML. CG is transplant glomerulopathy, and PTCML, that is peritubular capillary basement membrane multilayering. So 7 or more than 7 layers in one capillary and 5 or more than 5 layers in two others. It is seen only on electron microscopy, and the criteria too is similar, that is C4D positivity and DSA positivity should be there. So chronic AMR is chronicity scores are there, chronic lesions are there, C4D being negative, but there should be prior documented a diagnosis of active or chronic active AMR and or documented evidence of prior post-transplant though or current positive DSA evidence should be there. So DSA should be positive and the chronic lesion should be there even if C4D is negative. Now other entities are also added. C4D staining without evidence of rejection, that means there is C4D positivity and all other rejection criteria, the activity lesions are not there. Microvascular inflammation or injury where the DSA is negative and C4D is negative, but at least moderate microvascular inflammation, that is glomerulitis and peritubular capillaritis, both should be 2 or more than 2. Individual peritubular capillaritis score 2 alone is not sufficient. G at least should be more than 1 or equal to 1. So what is probable AMR? When there is glomerulitis along with peritubular capillaritis and the chronicity scores are absent and C4D is negative, but DSA is positive. That means when there is microvascular active lesions are there and DSA is positive, well, then it is probable AMR. C4D staining with acute tubular injury. Earlier, acute tubular injury was included in criteria first of active AMR, but now it has given a separate entity when the 3 criteria, that is presence of acute tubular injury should be there, C4D positivity is there, and there should not be any microvascular inflammation. This type of changes are seen in cases of ABO incompatibility, like we call it accommodation. Case number 5, 54-year-old male, known case of ADPKD, CKD on maintenance hemodialysis, HCV positive, live related donor transplant a month ago, and donor being the sister. On triple immunosuppression, hypertensive, worsening RFT, serum creatinine 4.5 mg per dl. This is a low power view of renal biopsy showing moderate acute tubular injury with flattening and denudation of the lining epithelium along with loss of the brush border. 3 glomeruli are seen. Even at this magnification, we can see there is a large artery seen at the edge of the biopsy and some intimal fibrosis. This could be donor related. And there at this magnification also something is occluding in this capillary lumina, or this we can see. On further magnification, these are the afferent arterioles or hilar arterioles seen occluded by fibrin thrombi. Why this is fibrin and not hyaline? Because these are not glassy smooth as that of hyaline. These are having the fibrillary or amorphous or granular appearance, and there is some mesangiolysis. It is PS positive. On further evaluation on mesenterichrome stain, these thrombi are fusionophilic, confirming as fibrin thrombi. So, and C4D was negative. The diagnosis was features of de novo thrombotic microangiopathy. There is associated moderate AT acute tubular injury, but there is no evidence of rejection. On further evaluation, tacrolimus level was 18 nanogram per ml. So it was TMA due to TAC toxicity. So what other changes we can see in other compartments of TAC toxicity? So this is a silver stain, best for this collapsing glomerulopathy. This is a collapsing glomerulopathy where can be a segmental or global collapse of the tuft. Here it is segmental collapse of the tuft along with hypertrophy and hyperplasia of the overlying podocytes, along with this presence of protein resorption droplets. And there is isometric vacuolization of this proximal tubular epithelial cytoplasm. We have to see whether it is isometric or not, because in cases of hypokalemic nephropathy, we can see large irregular clear vacuoles in the tubular cytoplasm, epithelial cytoplasm. So here they are isometric, characteristic of CNI toxicity. There is CNI arteriolopathy. This is an arteriole and it is showing ballooning of the smooth muscle cells of arteriole, and there is luminal calcification in the tubules. Striped fibrosis, that is, there is alternate bands of fibrosis, interstitial fibrosis is seen. This is the preserved cortex and this is interstitial fibrosis. So alternate bands are seen of interstitial fibrosis, characteristic for CNI toxicity, mostly seen in late CNI toxicity. This is arteriolar hyalinosis and it is nodular appearing or pearl-like appearing, which is characteristic for CNI toxicity. In cases of diabetes and hypertensive hyalinosis, it is intimal hyalinosis. Intimal hyalinosis is seen, but in cases of CNI toxicity, it is muscle layer is involved. It is intramural hyalinosis. 46-year-old male, coming to next case, 46-year-old male, renal transplant recipient 4 years ago, donor being wife, slow rise in creatinine 1.7 milligrams per deciliter, hypertensive on triple immunosuppression. Clinical DD was chronic ABMR or TAC toxicity. So here we can see moderate amount of tubular atrophy and interstitial fibrosis is seen. The glomeruli apparently looking normal. On further magnification, on HND stain section, we can see these tubules are showing some smudgy appearing intranuclear inclusions. Also some with a halo. So type 1 and type 2 polyomavirus nephropathy inclusions are seen. There are 4 types of inclusion. Here, these 2 types of inclusion are seen, and these tubules which are showing these type of inclusions, intranuclear viral inclusions, they are showing tubulitis, not the other tubules. SV40 stain is strongly positive in this intranuclear inclusions. So it was consistent with polyomavirus nephropathy class 3. So PVL scoring is given in available all cores, cortex and medulla. Here comes the importance of medulla in a renal allograft biopsy, where we can score the SV40 staining in the polyomavirus nephropathy, and also C4D positivity is also scored in medulla, but not the peritubular capillaritis, remember. So PVL1 is less than 1%, 1 to 10% is 2, and more than 10%. So ours was PVL3 and moderate tubular atrophy, so it becomes class PVN class 3. Other viral inclusions are seen. This could be intranuclear or cytoplasmic. This is Auli inclusion and showing some cytoplasmic granule characteristic of CMV nephritis. This is a ill-defined non-necrotizing granuloma showing epithelioid cells and some multinucleated giant cells. Whenever we see a granuloma, we should look for fungal infection. So this is GMS stain, fungal stain, Gomoris methanamine silver, showing mucormycosis. These are broad aseptate hyphae showing right angle branching and confirming histomorphologically as mucormycosis. Whereas in aspergillosis, there is acute angle branching and these are septate hyphae. This is a case of candidiasis showing budding is and pseudohyphae. In case of tuberculosis, we get to see this necrotizing caseous necrosis, granulomas and epithelioid granuloma, central caseous necrosis surrounded by epithelioid granuloma, epithelioid cells and Langhans type of giant cell. So this is, and also modified Zn stain sometimes may show AFB bacilli. This is a case of malakoplakia showing Michaelis-Guttman body. This is a macrophage termed as von Hasselmann cell, and this is seen in the cytoplasm of this macrophage, giving a bird's eye appearance or targetoid appearance, showing positivity for von Cosa stain for calcium, and also for Prussian blue stain will also be positive for iron as it contains calcium phosphate and undigested bacteria. Neutrophilic tubulitis and neutrophilic casts are characteristic for acute pyelonephritis. So to summarize, donor source some clinical information is important, like donor source, whether it is live related or disease, duration post-transplant, drug therapy, CNI drug level, native kidney disease, renal function, degree of proteinuria, in glomeruli, whether glomerulitis, fibrin thrombi, transplant glomerulopathy, in tubules, acute tubular injury, proximal tubular epithelial cell vacuolizations, neutrophilic casts, granular casts. Also, apoptotic casts are seen in cases of polyoma virus nephropathy, tubulitis, tubular atrophy, viral cytopathic changes. Interstitial inflammation is important, the degree, the type of inflammatory cells, whether they are eosinophils or plasma cells, then it becomes a difficult refractory T-cell mediated rejection. Also, when we see plasma cells, then look for BKV, interstitial fibrosis and interstitial hemorrhage. Interstitial hemorrhage is seen in both types of rejection, that is T-cell mediated and antibody mediated rejection, but mostly it is seen in antibody mediated rejection. That's what the books say. Peritubular capillaritis, arteriolar hyalinosis, endarteritis, transplant arteriopathy, and thrombotic microangiopathy, TMA. Compare with the previous biopsies for progression or resolution of dysfunction. Discussion with the nephrologist is very important before signing of the report. Every attempt should be made to give a diagnosis, notwithstanding with the size of the biopsy. So thank you very much. I would like to thank ISOT for giving us this platform, and I hope this course has been added some value in your understanding of renal transplant pathology. And thank you all for attending the course, and thank you for being there. Thank you.
Thank you, ma'am, for your wonderful presentation. As there are no question and answers from the audience, so I would like to thank Vrushali madam and Radhika madam.
Thank you.
On behalf of ISOT, I would like to thank the participants present today. Any final comments, ma'am?
Yeah, I would like to thank all the speakers till now for this course and all the attendees. So now only one lecture is left, and then we'll be updating about the exams. Yeah, that's it. Thank you, sir. Thank you for moderating.
Thank you. Thank you.
Thank you, Dr. Vrushali. Thank you, dear all.
Thank you, ISOT, and thank you, ma'am, for this wonderful opportunity.
Thank you.
It was a great pleasure. Thank you.
Same here. Thank you.